Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. This presentation is about medical error, and it's Dr. Muhammad Farid Tabib. I'll start with a news in the newsletters and a location, an internet location. Last week, it's about central event happened in United States. And it was shown on a Fox paper location in Emirates. It's talking about a 34 years old male. He's a cardiac patient. He feels unwell, called 911. They took him and delivered him to the hospital. He said that inside the hospital they asked me, do you have pain? Do you need analgesia? He said yes. So they gave him some anesthesia, and by mistake they delivered him to the cesarean room. And instead of taking him to the cardiac room, they took him to the cesarean room. And they started to do cesarean section for him by mistake. They thought that he is a pregnant female, despite he's a male and he's a cardiac patient. He said that they discovered the issue after half an hour from surgery. They did not find a baby, they cannot find a uterus, and they discovered that they did a mistake. The man sued the hospital, and he's asking them to pay $1.2 million for him. So medical errors are happening in everywhere, in a developing country, in a well-developed country, in everywhere. So our presentation today will focus about the medical error, what's the types of error, how errors occur, and how do we have to react with the medical error. What's our objectives? Talk about some definitions related to errors. How common is the errors? How does errors happen? Why it's happened? How would we think when an error happened? How do we have to think? And how should we respond to those medical errors? So let's. What's the medical error? Medical error is defined as preventable adverse effect of care, iatrogenesis, whether or not it's evident or harmful to the patient. Either causing harm or not, it's still a medical error. This might include an inaccurate or incomplete diagnosis, treatment of a disease, some injury, a syndrome, it's a behavior, it's infection, or any other thing happened to the patient. We call it a medical error. Again, there is another definition from IOM, which is the Institute of Medicine. They defined errors are failures. So errors are failures of one or two things. Failures of planned action to be completed or executed as intended, and we will call it error of execution. Or the use of wrong plan to achieve what's intended, and we will call it error of planning. So it's either error of planning or error of execution of the plan. So we will call them may be act of commission or omission. Commission means we commit something wrong. We did something wrong. Omission means we did not do the right thing. We forget, we omit, we removed something. What we have to do, we will call it omission. So this is the act of commission or act of omission. So what's the definition of adverse event? We define the medical error. Let's define the adverse event. Adverse events are events or incidents or injuries caused by medical intervention. And it's very important to know that it's not related to the patient condition. It's something we are the cause of. We will call it adverse events. A large proportion of adverse events are preventable. Hence, we call them the preventable adverse events. Adverse drug events are part of adverse events, and they can cause injury to the patient or side effects. We'll call them, it's because of medication. So it's a medication error. Again, there is another definition for adverse events. It's a preventable or non-preventable events that cause harm to the patient as a result of medical care. This includes never event, which we are calling the sentinel events. It includes also the hospital acquired condition. One of them is health acquired infection. Events that require life-sustaining intervention, and the event that cause prolonged hospital stay or permanent harm or death to the patient. All of them are types of adverse events. How common medical error? Is it common to have medical error? Just I offer to you since 1 month, a very big medical error happened in a well-developed country. So it's very, very common. I will show you now 2 studies showing or talking about how common errors are. It's a Harvard medical practice study, reviewed a chart of 30,121 patients admitted to 51 acute care hospitals in New York State in 1984. So the study happened in the United States, around 30,000 plus patients in 51 acute care hospitals. What they discovered? They discovered that 3.7% of an adverse event led to prolonged admission, and it's of course related to utilization, or produce disability at the time of discharge. Around 70% of those injuries were caused by medical error. So 70%, it's too much. Another study, which is Australian study, investigation reviewed the medical record of 14,000 plus admission to 28 hospitals in New South Wales and South Australia in 1995. What they found? They found that adverse event occurred in 16.6 of admission. It's too much. Every 100 admission, we have 16 plus, around 17 adverse event, resulting in permanent disability in 13.7 of those 16. 13.7 of them have permanent disability of patient, and death in around 5% deaths of the patient. So it's common, and it results in death. 51% of adverse events were considered to have been prevented. Could you imagine that 50% of the adverse event happened in the medical institute? 50% of them are preventable. We can prevent them. In Australia, medical error resulting in as many as 18,000 unnecessary deaths and more than 50,000 patients become disabled each year. It's a very big, huge number. In the United States, medical error resulting in at least 44,000 and may be reaching 98,000 unnecessary deaths each year, and around 1 million excess injury, and the cost a lot. They are talking about $4 billion annually. So what the medical errors will do to your healthcare facility, it will affect the facility reputation. It will affect the funds, because as much as you are doing or committing medical error, the funds will not be the same. It will be decreased. And don't forget about the second victim. Second victim is the medical staff that commit the error. Do you think about his thinking, his feelings? We will call him the second victim. So the patient will be the first victim, and the medical staff who commit the error will be the second victim. And the second victim will suffer too much, and he needs a lot of support. What are the types of the medical error? About half of the medical errors or adverse event occurring among inpatients resulting from surgery. So surgery is the main cause of errors. It could be the errors a complication from drug treatment, it could be therapeutic mishaps, and it could be diagnostic error. While we are doing a diagnostic maneuver or procedure, we can commit some medication error. So the operating theater is the main source of errors, and the medication also is a very big branch of medical errors. What about cognitive errors, such as incorrect diagnosis or choosing the wrong medication, more likely to have been preventable and more likely to result in permanent disability than technical errors. So cognitive errors are very, very big branch of committing errors as much as the technical errors. Offering you now a piece of a policy which we are working on in our healthcare facility, showing the types of error, discussing the types of error. What they said, upon formal notification of safety event, leadership inside the facility associated with the event will begin an investigation process to identify the types of the behavior that led to the safety event. Why this safety event happened? What's the type of behavior associated with it? Those three behaviors or actions are as follows. Number one, human error. And human error could be a slip or lapse or a mistake or unintended error and a product of a current system design that often fail to consider the impact of the human factor. Number two, at-risk behavior. A choice risk is not recognized. Risk of deviation deemed minimal or believed justified or underestimated. And the third one is the reckless behavior. Here we have intentional risk taking. He knows the risk associated with the action, but consciously disregard it. So those are the most important three types of human behavior related to the risk or to the adverse event or to the medical errors. I'll give it to you in details. Look at this table. Number one, human errors, inadvertent action like slips, lapse, or mistake. How can we manage it in our healthcare facility? We have to modify our processes, procedures, policies. We have to do a lot of training. We have to design or redesign what we are working on. So what are the console? Example, I'll give you example here. Slips are action not carried out as intended or planned. The plan is to do like this, but you did something against what's intended or planned to be done. Example, if two buttons are close to each other and you click the wrong one instead of clicking the right one, it is a slip. Example, move a switch up rather than down. So wrong action on the right object, it's a slip. The second one is at-risk behavior. Here, the choice is risk is not recognized. The staff underestimate the risk or did not recognize the risk or believed the risk is justified. It's something simple. He thinks that or he thought that. How to manage? By removing incentives from people that committing the at-risk behavior, creating incentives for people that doing the healthy behavior, increasing the situational awareness and training. Example, not checking a patient identification using two identifiers. For example, one nurse said that I will choose to check the patient identification by only patient name. No need to check the medical record number or social security number or what else. It's a risk. She's taking risk now. Instead, she knows that the protocol is to use two identifiers for patient identification. So this is the at-risk behavior. The third one is the reckless behavior. And the reckless behavior is conscious disregard of the unreasonable risk. I know this is risk, but I'm intentionally said that risk will not happen and I will not do it. Manage how to manage by remedial actions and punitive actions. You have to punish the people doing or committing this kind of errors because you have to implement a just culture inside your healthcare facility. What's the example here? Healthcare provider does not intervene to protect a patient because nurse is not assigned. For example, one nurse is finished her shift and she's leaving the healthcare facility while she's surprising that one patient developed cardiac arrest. She said that I'm off now. The next nurse, she have to come and discover it. This one is a reckless behavior and should be punished for this. Which patients are the most at risk? Always there is some patients are liable to risk to have adverse event or medical error rather than others. Number one, those undergo cardiac surgery, cardiothoracic surgery, vascular surgery, neurosurgery. Those patients with a complex conditions. Those patients in emergency room. Those patients are locked by inexperienced doctors or staff. And of course, older patients are liable to medical error rather than patients. This is a bar graph showing that the more the age, the more the number of adverse events and the medical errors. And the more the age, the more the number of preventable events. And the more the age, the number of resulting in permanent disability. So the more the age, the more the. How dangerous is healthcare? The medical error and the adverse events, it's very, very common and very, very dangerous in healthcare. We will offer here some comparison between healthcare and the other industries, like railways or railroads, the bungee jumping, and the mountain climbing. In nuclear power, European railway or railroads and scheduled airline, the suspected death is less than 1 in 100,000 encounters. In mountain or in bungee jumping, chemical manufacturing and driving, one death is less than 100,000, but we have 1 in more than 1,000 encounters. Let's go for the healthcare and mountain climbing. It's more than 1 death per 1,000 encounters. So it's very, very, very big. It's more than other industry. And I will tell you later on why adverse event and the medical errors are common in healthcare system. Why do errors happen? Because all humans commit mistakes. All of us can do mistakes. Make errors indeed. The ability to make mistakes allow human being to function. Most of medicine is a complex. That's the answer of the question. Healthcare is a complex industry and uncertain. It's not that clear. Most error results from the system, not from the persons. Inadequate training, long hours working, and people that looks the same, lack of checks, and so on. So the more the system errors, the more the errors will happen. And I believe we answered why it's more in healthcare, because it's a complex. Who to blame? Do we have to blame the individual who is the weak part of the chain, or we have to blame the system, which is the strong part? Of course, we have to blame the system and interdependent interaction of multiple human and non-human elements, because it's considering the humans and non-humans. It's the big one we have to blame is the system, not blaming individual. And I will tell you why. This is a very important tool in quality, which is the Swiss cheese model, invented by James Reason. He said that the more the barrier we are putting, the less the error will come. And of course, the barriers still have some holes, and the error or the harm will not reach to the patient or to the victim unless a lot of holes and all those holes are aligned in one line. So the error or the risk or the error will go through the holes and reach the patient. Here is an example for coronavirus, COVID-19. What are the barriers we put to prevent it from happening? We put the social distance as a barrier. We put the wearing masks as a barrier. Washing hands is a barrier. And rapid testing is a barrier. So the more the barriers, the less the medical error. The more the holes inside the systems, the barrier, the more the effect. All layers are important because each layer is not perfect. Single layer is not perfect. But all layers are very important to protect people or people from the error. How to think about error in a proper way? About individual? No. Only the minority of cases amount from negligence or misconduct, so it's the wrong diagnosis. If you diagnose any medical error by diagnosing it, it's the responsibility of X person, it's a wrong diagnosis. It will not solve the problem. It will probably, in fact, make it worse because it fails to address the real problem or the root cause. Doctor will hide some errors. If you are pointing to them, they will start to hide the errors. Not doctors alone, any healthcare staff, if you are pointing to them by finger that this one is responsible for the error, they will start to hide the error. May destroy many doctors, as we said before, the second victim. If you point at them, you can destroy them because they are victims as much as the first victim, which is the patient. So how to think? Think about the system. It's a system failure. This is the starting point of redesigning the system and reducing the error, is to think about your system. Where is the errors inside the system? Fix those points inside the system. Errors will decrease. What are the tactics? How I will respond to an error inside my healthcare facility? Reduce complexity and variation. Variation is the first enemy and is the main cause of almost all errors is variation. People are doing the same job by different ways. Optimize information processes. Start to invent some checklists, reminders, protocols. Automate wisely. Use constraint, for instance, with needle connections, for example. Mitigate the unwanted side effect of a change with training, for example. So the more you are trying to put some constraint about your things and redesigning your process and putting new protocols, checklists, or reminders, the less will be the number of the medical errors. Again, let's go about what James Reason states for building a safe healthcare system. Both principles: design and redesign a policies or modify your existing policies, put a procedure, improve your practice, always try to simplify the processes, do standardization, ask all people to do the same process, the same maneuver, the same protocol, process design, eliminate the sound like, look alike, it's regarding the medication, environment and product improvement, try to improve always, train the people more and more and more, try to work in a teamwork. All of this can help you to build a safe healthcare system against medical error. What about principles? Safety is everyone's business. You have to enforce this culture inside your healthcare facility. It's not the responsibility of quality and patient safety department or the hospital administration. It's everyone's business. Top management accept setbacks and anticipate errors. They have to share, they have to anticipate, they have to anticipate it. Safety issues are considered regularly at the highest level. You have to deal with the safety events in a sharp way. Past events are reviewed and the changes implemented. Always learn from your past. What about principles? After a mishap, management concentration on fixing the system, not blaming people. Understand the effective risk management depends on the collection of data, analyze data, and dissemination of them. Top management is proactive. They have to anticipate the areas of weakness and consider it as an initiatives for improvement and try to work in a team, doing brainstorming and search for root cause and putting action plan with monitoring. If you are working with that principles, the errors will be minimized. Policies: safety-related information has a direct access to top managers. Risk management is not a jail. Meetings on safety are attended by staff from many levels and departments. All levels, all departments have to share in mitigating the risk, knowing what's going on, how to correct. Messengers are rewarded, not shot. Please don't kill the messenger. The medical error is a messenger telling you that there is something wrong with your system. Do not shoot it by punishing some individual and leaving the error happening again and again and again. Top manager create a reporting culture and a just culture. As we said that if anything is intended, you have to punish them. But creating a culture of improvement and just culture inside your healthcare facility will reduce the errors. Policies, disciplinary system agree the differences between acceptable and unacceptable behavior and involve peers or peer reviews. You have to do the culture, as we said. Procedure training in recognition and recovery of errors. As soon as the error happened, do not destroy your facility. Try to discover what's wrong. Try to build an action plan not to happen again. So training and recognition, how to recover from error. Feeding on recurrent error pattern, an awareness that procedures cannot cover all circumstances on the spot training. Protocol written with those doing the job. Procedure must be intelligible, workable, and available. Procedure. Clinical supervisor train their charge in the mental as well as the technical skill necessary for safe and effective performance. So always train people, and it's better to be on-job training. Advise your people, help them, support them, give them tips and guidance and assistance. Practice rapid, useful, and intelligible feedback on lesson learned. Always learn from your past, from your errors, and try to not to do it again. Bottle up information, listen and act on, and when mishaps occur, acknowledge responsibility, apologize that we did something wrong, and always learn from your lessons. Fallibility is a part of human condition. This is a fact. We cannot change the human condition, but we can change the condition under which people work. The old way is change people, and the new way is change the condition under which people are working. Change, fix your system. Conclusions: human beings will always do mistakes. Errors are common in medicine, and it's killing tens of thousands of people. We begin to know something about the epidemiology of error, but we need to know more and more and more. Naming, blaming, and shaming have no remedial value. It will make it worse and worse and worse. We need to design healthcare system that puts safety first. First, do no harm. This should be the culture in every facility. Do no harm. We know a lot about how to do that. It's a long, never-ending job. It's a very long journey. Do it today, then do it again tomorrow, and do it again next week, next month, next year. Always you learn from the lessons and correct yourself. It's not ending. It's a never-ending journey. Thank you very much. Assalamu alaikum wa rahmatullah.